Hello, I'm delighted to be with you here today. I would describe myself as a zealot for innovation, and whenever I hear the words outcomes research or comparative effectiveness, I see a boogeyman. So I'm going to be a little bit of an ice water bucket on some of the concepts today, but all in a very good way. It's all about getting more products approved out there to help patients. So there's basically 6 things I want to talk about. The first is that you can't let our love of science, we all want data and we all want outcomes, but I just don't believe we have the tools we think we have. Think about genomics. That was going to solve everything. Then epigenomics. Now there's a code in the way the DNA folds. There's going to be a code in the 4th cysteine from the 1st intron divided by the 7th thymidine from whatever, cubed. Okay, that'll be a code too. So we think we have so much, and we don't have that much. And if we wait for innovation and do outcomes research based on the tools we have today, we're going to have nothing. Second, all of the research we do is based on the results in the average patient. And that obscures individual medicine. And it obscures observational medicine, which happens all the time. Serendipitous discovery. So again, I don't want these kinds of things getting in the way of getting products approved. The third is that people use outcomes research against innovation. And that happens a lot with drug approvals. So whereas, my 4th point, there's probably 2,000 drugs in the pharmacopoeia, 200 are used the most. How do we go from 2,000 down to 200? Well, that's the medical marketplace. That's doctors experiencing it. That's outcomes research after drugs are approved. When they're used beforehand, I think that puts too much of a governor on innovation and doesn't allow it. So let's talk about, my 5th point is that single drugs curing diseases, every so often that's going to happen. But the low-hanging fruit is gone. Our most vexing medical problems are going to happen with combination therapy. How are you going to get combination therapy? Can you get 3 novel drugs in clinical trials before they're approved? No. Even if they're under the same house in the one drug company, you're not going to see that. So the way to get combinations is getting a drug approved, and then once it's approved, drugs are used combined with it. If we wait on the outcomes for that first drug, it'll never happen. If the outcome we're looking for is 5 or 6, but the first drug gets you to a 2, take the 2. Okay? So let's go through 4 drugs that have been in the news recently, and we'll explain what's going on here. So the DMD drug, Exondys, this was a heck of a drug. Now, the problem was the FDA didn't like the study that was done. But 10 of 12 boys still able to walk after 4 years versus 3 of 13 in the historical control group. At the panel meeting, the FDA said, no, if these results were from a well-designed and interpretable trial, there likely wouldn't be much to talk about, meaning that the data were quite compelling, but from the wrong kind of study. So that's why you have panel meetings. So let's ask the panel. Well, Asma Gamey and I, a graduate student, did research on all the panels of this decade. And only the cardiovascular panel asks the question the way the regulations say the question should be asked. Do you recommend the approval of X drug for Y disease? Cardiovascular does it all the time. You can see so many other groups don't do it. Well, what did they do for this drug? Well, they asked that question. Okay, and so one of the panel members said, based on all I heard, the drug definitely works, but the question was framed differently. And so all the anxiety you've heard over this drug is because the panel was wrong, was conducted wrong. Right? It's not about the drug not working. And at the panel meeting, this is the kind of slide they put up to the FDA. What is your job? Your job is to protect the public health. Well, if your job is to protect the public health, what are you going to do? You're going to vote against everything. Your job is to promote the public health. I don't want outcomes research blocking promoting health. All right, so let's go to the next drug here. So saralexin. What a great mechanism of action. This is for heart failure. It's human relaxin, which is secreted by pregnant women so that they can cope with the additional cardiovascular demands during pregnancy. Great data in phase 2, showed reduced dyspnea, but because there was an ongoing outcome study The panel said, let's wait to see those data. The data came back, and there was no survival advantage. So even though the drug has an effect, and it would be a perfect kind of drug you'd want to combine with other agents later, it got turned down. And there you go. You see the serelexin groups in fuchsia, and you see all the biomarkers. Nice drug, but it didn't show the long-term outcomes. So not approved. Now, the FDA gives good lip service to the concept of using biomarkers, right? But they want to make sure the biomarker is validated. Well, let's see what they mean by validated. Cholesterol, lowering cholesterol. I don't know of any biomarker more validated than the benefit of lowering cholesterol. Let's look at Repatha. So Repatha gets approved. It's lowering, with a single injection, it's lowering cholesterol 60%. Data that had never been seen before, okay? So, but in order, and this is the approval that they got, very, very narrow claim. To get the approval for general lowering cholesterol, they had to do a 27,000 patient cardiac outcomes trial. And they did it, and it's approved. But my point is, don't believe a word you say about drugs in the future being approved on biomarkers. Ain't going to happen. If lowering cholesterol is not considered a validated biomarker, nothing ever will be. And that's not good for innovation. And again, these are the people, many people who advocate outcomes research. This is the kind of stuff they're talking about that frighten me for innovation. Let's look at another drug. Alzheimer's disease. We have no more grave medical problem than Alzheimer's disease. So here's a drug. So many have failed. Here's a drug that showed many secondary clinical endpoints, directionally favored the drug. In fact, the principal investigator of it said, I have several patients within my practice who were hoping to take this drug, she said, but it was at least encouraging that patients taking the drug showed improvement, just not enough to be statistically significant. And she wants to evaluate the data to see if changes in the design of the study could happen. But the drug was active. It showed some signs. And this is a great example of, if we really want a 6, but a drug gets you a 2, why not get it out there? This would be one of the ones that I think we'd want to see. So that leads me to my 6th point, and that is this. I have no problem with outcomes research. I have a problem with the duration of it. So the longer the endpoint, survival, for instance, the longer the endpoint, the more factors that you can't control for in a clinical trial can skew the results. So ideally, when you run a study, you want to make sure there's a balance of people with factors that you think are important in modulating the disease. You want to make sure both groups have it, right? So, but how do you control for death of a dog, loss of a child, loss of a spouse, divorce, things that are psychologically debilitating, right? How do you control for that in studies? You can't. If you controlled for everything, the studies would be even longer and larger. So that's why I believe the shorter term the outcome, the more reliable a drug effect can be shown. So I've proposed approving drugs on the basis of 4 things. Biomarkers, lowering cholesterol, lowering glucose, lowering whatever, like the heart failure drug with serelexin. Clinical signs and symptoms, okay, the patient feels less pain. The blood pressure goes down. The cardiac output goes up. Okay, approve it on that. Why do we need survival? Disease modification. So someone with ulcerative colitis, okay, they used to have, let's say, 50 bowel movements a week. Now they have 3. That's nice, good endpoint. And then, of course, if you go and do the studies and you do show there's a survival benefit, of course, based on approval on survival, on clinical outcomes. So I think this paradigm would allow drugs to be approved. There'd be differential claim structure. Payers might even pay differently based on the evidence that the company did amass, and that would be okay. So once again, I don't want outcomes research and comparative effectiveness being done pre-approval. I want to get drugs that are active and are safe, got to be safe. We keep learning safety as we go, of course, but drugs that are active and safe, get them on the market My biggest reason for that is because combination therapy is really the key to the future, and the only way to get combinations and serendipitous combinations and serendipitous observations in the clinical setting that can truly help patients is if we get drugs and biologics and devices out on the market as soon as possible. So, any questions? Yes?
You're going to shorten the length of a trial. You're also going to risk not seeing some of those acute changes, or long-term changes that may occur that you didn't account for. And I guess
Long-term toxicity you're talking about?
right,
Yeah.
long-term effects on a drug. If you're pushing for a shorter window, how would you account for that?
Right. It depends on how short the window is, right? So I like statistics, don't get me wrong. I want statistical proof that the blood pressure was lowered or there was disease modification. You know, there's a concept that drugs are safe, and that's not it, right? We learn how to label drugs for safe use, and that learning occurs throughout the life cycle that the drug is on the market. So I understand your point entirely. I think we have to be reasonable in saying, gee, do we want at least 3-year follow-up data before it's approved? I'd live with that. I just don't want 8-year. You know, I don't want to wait 8. But I don't want 2 weeks either, okay? So I'm with you. I think we need a reasonable, longer-term follow-up period so that we have some confidence, continued learning in the marketplace. Great question. Any others? All right. Well, thank you for your attention.